Hello and welcome to this, which is now our sixth episode of CancerFace, our weekly vlog. Now, you may have felt a few seconds ago a sensation of being pulled towards us, and that was, I'll just explain that for you. Up until now, we've been recording these 2 weeks in advance of them actually being put up on YouTube. But it's a fortnight since we recorded the last one, so you're now 1 week behind us, as it were, whereas before you were 2 weeks behind us. So that that pulling sensation you felt was actually pulling you through the space-time continuum, so that you're now just 7 days behind us. So it isn't it, Nupsy? And what's that? What is he? No, that couldn't happen. No, Nubbins wondering if as you're catching us up in time that you might eventually overtake us, but that would mean you'd be watching this before we'd actually recorded it, and that's not particularly likely, lads, but I can see you thinking. Okay, so what have we got this week? We've got your correspondence, as usual, and then we're going to describe the main event of the past fortnight, as it is, which is this multidisciplinary team we went to, the MDT team, where they were due to tell us the results of the biopsy of the throat, or of the tongue, I should say, and also discuss treatment options with us. But we'll also have our regular features. We'll have regular features, one of which I know is very popular with the cognitive behavioural therapy community, which is looking on the bright side and thinking about the positives of cancer. And also we'll be continuing our series on how to talk to people with cancer, because I know that's something after last week that many of you found particularly useful. But we start as ever with our correspondence, and we've had a letter from an email actually from Elizabeth Johnson from Trowbridge. And I don't know if you remember, but she contacted us an earlier episode, saying, I think on that occasion, that she thought that my diagnosis and all that was all made up. Anyway, she signed herself Betty this time, which means perhaps we're becoming a bit more friendly. And she writes, "Not only do I think that your diagnosis is fiction, I believe that the entirety of your little show is based on falsehoods. Your so-called correspondence seems to me to be entirely made up from people who don't really exist, and that might even include me, although I'm less sure on this latter point. As for your claim to be able to communicate with your dog, what do you take us for? Yours affectionately, Betty." Which is interesting, isn't it, that? Because that actually chimes with something that we've been talking about this last week. Not so much Betty's ontological status, but rather problems or issues that some of you might have with Nubbins' communication. And that's quite pertinent, because it looks like the main treatment option I'm going to be having, I'm sure the main treatment option is going to be radiotherapy, which can make your mouth incredibly sore and make it very difficult to speak. So we've been wondering what's going to happen to the vlogcast during those weeks. And Nubbins very kindly offered that one option might be that I can just sit here looking kind of ill and poorly, whilst Nubbins tries to communicate to you the events of the past week using entirely the medium of modern dance. I'm not totally sold on this idea myself yet. I'm not totally sure of your abilities to understand the points he's trying to make, but we'll bear that in mind. So, this last week we went to the multidisciplinary team meeting, the MDT, which we'd been warned in advance was going to be quite a big meeting in terms of the number of professionals there. And also we were warned in advance that there could be a delay from our appointment time, because it's very much an opportunity for us to ask questions, and the people before us, of course, may well have had lots of questions, and indeed it seems they did, because we were over an hour late in our appointment, but we've been warned about that, so that was okay. So we went in, Sally and myself were led into this the room. Not a huge room, about twice the size of this, and in it was obviously a clinic room, and in the room there was a kind of dentist's chair. You're comfortable with that. And this dentist chair was obviously a chair for examining patients in normally, but I was kind of sat in this dentist chair, which was upright obviously because it was for a meeting, facing the two consultants. There was the ear, nose and throat consultant, who was a male, who was a very affable, cheerful fellow, and there was also a female oncology consultant, who was a bit more severe. It was a bit like they were doing good cop, bad cop routine between them. But they were there, and then along the right-hand side of the room, my right-hand side, there were a few other professionals. There was a speech-language therapist, there was a dietitian, I think the nurse was there, there was a medical student, Sally, my partner, was sat there. But it was interesting because I was sat facing these two consultants, and they called it an MDT meeting, and I spent a lot of time as a health worker in MDT meetings of various kinds, and it was very much the consultant show. Nobody else spoke actually, apart from Sally, during the whole meeting. And as I said, the very affable ENT consultant kicked off and said, we could see that I'd taken in some questions that were written on some papers that I had, so he just very much invited me to ask my questions, and my questions of course were about the cancer and what it revealed. And it seemed like they didn't get that much from the biopsy, which they did, which was a shame. But they did tell me it was a squamous cell, I'm not sure that's the right pronunciation, squamous cell carcinoma, quite large. They don't commonly metastasize, he said, but when they do, they tend to go locally, and they don't normally go to the brain. But you can only see those things, of course, with a PET scan. But what makes me think they didn't get such a great sample was that they wanted to find out if this HPV virus was involved. It's involved in a lot of throat and neck cancers and tongue cancers. And because they wanted to find out, one of the reasons was there's a much greater success rate for the treatment they're proposing if it is HPV. I think it's called human papillomavirus or something like that. And there's a 70% success rate if HPV is present, but only 50% if not. And by success rate, I mean that means that that they eradicate the cancer completely from the area. But he invited me in, the ear, nose and throat consultant, the following week. He wanted me to go in, and together, he said, that together we will do a what they call an ultrasound guided biopsy of the lymph gland, and we would do that to try and find out this HPV status. But he was very much, we'll do this together again, and I felt like saying, but didn't, that I hoped he knew what he was doing, because frankly, if we're doing it together, I would have a clue what to do. But I think he was trying to be inclusive, and he then handed over to the female oncology consultant, and she described the treatment regime. We had a bit of a red herring because she thought I might be eligible for some trials, but because of the BCG treatment for my bladder, we discovered I wouldn't be eligible for any of those. So I'll get the standard 6 weeks of radiotherapy. That's 15 minutes per day, 5 days per week of them blasting me with radiotherapy, and once a week before the radiotherapy, I'll be having chemotherapy, which takes about 5.5 hours, and it looks like I'll be having that on a Friday. So that's the plan. Preparation wise, I've got to go in this next Monday, and they make a mask for you, a strange kind of mask, which is to assist with them making sure they point the radio beams or whatever it is to the right spot. And then I've got to have on Tuesday a CT scan, and on Wednesday an MRI scan, all to enhance the accuracy, I think. And then I've got a few days off, and then the treatment starts the week after. Although 2 days before the treatment starts, I've got to go in and have a peg fitted, so that I can, because my mouth will get very sore, swallowing will get very difficult, but I don't want to lose any weight, because if I lose weight, the mask won't fit so well and it'll all get a bit less accurate. So I can top up my feeding with this peg feed, which will fit, I think that's a week on Tuesday. Side effects do sound pretty grim. The whole of the mouth area gets very sore and inflamed, particularly I think your gums and such like. And the chemo can make you feel quite fatigued and kind of wiped out. But these things are just going to have to be borne, really. And then 6 weeks after this all finishes, so I won't finish until when we'll be kind of mid to late September. And 6 weeks after I've finished, we have a review, and 12 weeks afterwards, they have a PET scan. Do a PET scan where they'll be able to see, presumably, whether the cancer's been eradicated or not, as the case may be. So that's it. And then afterwards, we saw the Macmillan nurse on her own and went through a few practical things, including, and that's this week's positive, folks. This week's positive about having cancer is that she filled out a form where we get cheap parking at Middlesbrough Hospital for as long as the cancer treatment is in action for £10.30, I think it was. We can park day or night at James Cook Hospital in Middlesbrough. And apparently at Scarborough Hospital, if you're having cancer treatment there, parking is free. So those are two big pluses of having cancer. You really can save money on your parking. That's just about it. I just want to mention one other thing. Oh, yes, sorry, I said, didn't I, that we'd continue with our how to talk to patients with cancer. This is an interesting one. This is something to avoid, really, because I think it's very natural when you hear that someone's got cancer, particularly when you meet them, to tell them about success stories you've heard of people who've had a similar condition. So it might be say that, you know, I've got diagnosis of stomach cancer. You might come and say, oh, my Uncle Tom had stomach cancer and they treated him and they cured him completely and he's right as rain. And this is meant to reassure us, but I think it can have, particularly if you've got a man like mine, quite the opposite effect. Because if you think about it, supposing I've got a type of cancer that 20 people, say, have got in this country at one time, and we know it's got a 60% success rate. So we'll know that 12 out of those 20 people are going to survive. And you come and tell me about your Uncle Tom who survived, and I think, oh, well, that means that there's now only 11 people who are going to survive out the remaining 19. And that means 58%. 11 over 19 is 58% of people. So my chances of survival have dropped 2% by your telling me about your Uncle Tom. Now, if you came to me instead and said, now my Uncle Bernard had a cancer very like yours, and he died, I'd think, well, that's good, because that means there are still 12 places left for those people who survive, and it's down to 19, the number of people. So 12 over 19 is actually 63%, which means that my chances of survival have gone up by 3%. So if you really want to boost the morale of the cancer patient, tell them as much as you can about people with similar conditions who sadly the treatment was not successful. On that bright note, I hope you have a very good week, and I look forward to seeing you next week when I'll describe the various appointments that we've been to. And Nubbsy here will be much more awake, won't you, lad? You're a sleepy boy today, aren't you? Okay. See you next week.